guys, this is Mrs. Spinks Bowen. We're going to be talking today about asthma in the pediatric patient. So we'll have a separate lecture later on about other respiratory disorders, but today we're just going to be focusing on asthma. It's a big topic, and it's important for you to be very comfortable treating pediatric asthmatics because they will be so prevalent in your practice. About 10% of the pediatric population has asthma in Georgia. That can be as high as 13%. So it's really important that you have a good understanding and a good knowledge base of taking care of the pediatric asthmatic. So just as a quick reminder, let's just talk really quickly about what makes up the upper airway versus what makes up the lower respiratory system. So our upper airway includes the nostrils, which remember warms and humidifies the air as you breathe in, the mouth, the nasal cavity, the throat or the pharynx, and the larynx. Lower respiratory system includes your lymph nodes, the trachea, the bronchi, and the lungs. So both right and left lung, and then also the diaphragm. And when you break that down further, it goes into the bronchioles and the alveoli. So there it is, all laid out for you, the upper respiratory tract and the lower respiratory tract. So what is asthma? According to the National Heart, Lung, and Blood Institute, asthma is a chronic lung disease that inflames and narrows the airway. It causes recurring periods of wheezing, chest tightness, shortness of breath, and coughing. The coughing occurs at night and in the early morning. So just some facts about asthma. It is the most prevalent disease in childhood. It affects about 7 million children in the United States. It's the leading cause of school absenteeism. You can see there more than 13 million days of school are missed annually because of asthma. And that's a lot of missed school. And what else happens when the kids miss school because of asthma? The parents miss work. So not only does it affect the child's attendance and therefore their learning, but it also affects time and attendance in the parents. Nearly 11% of Georgia's children have asthma. If you look at children who have at any point in their lifetime been diagnosed with asthma, that number goes up to 13%. So perhaps they've, quote, outgrown asthma. If you take those kids into consideration, then that number goes up to 13%. In 2014, there were 25,141 asthma-related visits to the emergency department for kids under the age of 18. And there were 60 deaths from 2001 to 2011 in less than 18-year-olds. In 2014, we began reporting asthma mortality. So the Department of Public Health began to mandate reporting of deaths related to asthma. Prior to that, there was no mandated reporting. So you might just see a death certificate that said the child died of respiratory failure. But now the mandated reporting is a form that is on the Department of Public Health website, and you do have to complete that form, and that allows us to track, and the Department of Public Health to actually track deaths from asthma versus just deaths from respiratory failure in general. So the demographics of asthma, it's the most common chronic illness in children in the United States. In 2014, 8.6% of the population of children in the U.S. had a diagnosis of asthma. So you can see here in Georgia, we are above the national average. The incidence has been increasing in numbers in the past 20 years. Nobody's really sure why. There are lots of different theories out there, but just know that the numbers have been growing up. It's more common in pre-adolescent girls, pre-adolescent boys. So it's more common in pre-adolescent boys. After puberty, girls tend to predominate, and it's more common in African Americans and in Puerto Rican Hispanics. There are some significant disparities in asthma. African Americans are 3 times more likely than Caucasians to be hospitalized or have a fatal event from an asthma exacerbations. Puerto Ricans have the highest rate of attacks and asthma-related deaths. The percentage of African Americans and Hispanics taking daily medicines for asthma is significantly lower than Caucasians, even though they tend to have a higher prevalence of asthma. Children visit the emergency room and are hospitalized twice as often as adults with asthma, and women account for nearly 2/3 of all deaths from asthma in the United States. So that's women out over the age of 17. So it's important to understand the pathophysiology of asthma in order for the treatment of asthma to become somewhat of second nature to you. So it's really important to have a good grasp of pathophysiology. Remember, it's a chronic disease. It's manifested by airway inflammation and reversible obstruction. So initially in an asthma attack, there's a release of inflammatory mediators causing activation of other inflammatory cells. This causes changes to the epithelial integrity and airway tone. There's an increase in reactivity in the smooth muscles of the airway, and that results in the wheezing and the dyspnea. The other caveat of asthma is that it is a reversible obstruction. So the inflammation and edema of the mucous membranes and accumulation of thick secretions from mucus glands and smooth muscle spasms in the bronchi and bronchioles can all be reversed to some extent. So that doesn't mean that it's always reversible, such as in status asthmaticus, it may take more than a breathing treatment to reverse it, but it is in general a reversible obstruction. So there is just a little illustration of your bronchioles during an asthma exacerbation. So you can see the normal bronchioles there on your left, so on the right side of the screen, but your left. And you can see that everything is nice and loose. You can see the bands around the outside are nice and loose. That's the bands of musculature. You can see that there's no edema in the center of the airway, and there's no mucus. On the right side, on our right, so on the left side of the screen, it's an asthmatic bronchiole, and you can see the edema in the epithelial level. You can see the bronchoconstriction, so see those bands of muscles that have tightened up and caused bronchoconstriction, and then you can see an increase in mucus in the airway. And all of these cause the manifestations of asthma. They cause the signs and symptoms that we see and we hear: the retractions, the wheezing, the coughing, the throat clearing. So the etiology and risk factors for asthma, it's not, as I mentioned before, it's not fully understood. Atopy does appear to be the strongest identifiable risk factor. Most asthmatics have some sort of allergic sensitization, and early life sensitization to aeroallergens is a critical risk factor for asthma. Heredity plays a role in asthma. Maternal history tends to be a stronger predictor than paternal history, but history in either side of the family does predict a tendency towards having asthma. Gender, we talked about in our previous slide, as we did race. Respiratory viruses also play an important role in the development of asthma. So RSV and human rhinovirus in particular seem to play a big role in developing asthma. With RSV, there's an association between RSV and wheezing, as well as the severity of RSV with the asthma risk and severity as the child gets older. So children who get RSV do tend to have a higher incidence of asthma as they get older. Rhinovirus infection in the first several years of life is also associated with a 10-fold risk of developing asthma by the age of 6. So this risk is worse if the child has allergies. So you can see why it's important to protect and talk to parents about protecting children from these viruses in early years whenever possible. Environmental stimuli such as pollution or cigarette smoke does seem to contribute to the development of asthma. Noxious chemicals like strong chemical odors, and then nonspecific inflammatory responses to stimuli such as exercise or emotions. Now, some of the common triggers we see for asthmatics include allergens like dust mites, pollen, animal dander, mold, cockroach droppings. Here in Macon, cockroach droppings are a big issue. We grow cockroaches in Macon that are the size of small dogs. And their droppings tend to cause a significant increase in asthma exacerbations. So we have a higher incidence of asthma in Macon than in other parts of the state. Environmental allergens or agents also play a role, such as pollution, smoke, and odors. Also, respiratory viruses, like we mentioned earlier. GERD actually plays a role. So, how that works is when a patient, when a child refluxes, they tend to aspirate some of the refluxate. So we call that microaspiration. Just a little bit of the refluxate goes down into their airway. Well, what do we know about refluxate? It's very acidic, so that aggravates the airway. And when the airways are aggravated by the refluxate, it tends to cause the same sort of response, an inflammatory response, just like any other trigger. So GERD does tend to contribute to asthma and to asthma exacerbations, and we always question pediatric asthmatics about symptoms of reflux, and we treat the reflux. Sometimes when you treat the reflux, the asthma will go away. Cold air is a trigger, weather changes that can be hot to cold or cold to hot. Exercise can sometimes be a trigger. Emotional factors and medications such as aspirin can sometimes be a trigger. So when you're talking to a patient who presents with a cough or wheeze, you want to make sure that you take a thorough history. You want to ask about a family history of asthma or atopy. So maybe nobody in the family has asthma, but perhaps they have another of the atopic diseases, either eczema or some form of allergy. So take a good family history. Ask about conditions associated with asthma, like allergic rhinitis, eczema, or GERD. Ask about complaints of chest tightness or dyspnea. Ask about coughing, particularly at night and early in the morning. Now, sometimes kids with allergies will cough when they first lay down, and then when they first get up in the morning. But asthmatics tend to cough not only during that time, but also they cough during the night. Ask about cough or shortness of breath with exercise or exertion. You want to ask about their symptoms and whether they're seasonal, continuous, or episodic. Ask about episodes of recurrent bronchitis or pneumonia. So what will oftentimes happen in asthmatics is that because they may present with sort of a wet cough, or they may have some airway changes on chest x-ray, sometimes they're misdiagnosed as having bronchitis or pneumonia. And you'll especially see recurrent what we call afebrile pneumonias. And let me just tell you, there are no afebrile pneumonias in the pediatric population. So if you have a child that comes to you and says, golly, I go to the ER or to urgent care, or my child does 2 or 3 times a year with bronchitis, and they get a Z-Pak and a burst of steroids and they get better. Or the same thing maybe with pneumonia, and they get steroids and either a Z-Pak or some antibiotics, and they tend to get better. Let that be a red flag for you that there could possibly be that they have asthma. Bronchitis also is not common in the pediatric population. That is a disease caused by damage to the airway. That's usually in smokers. We just don't see that very often in children. Now, we will see bronchiolitis, but not bronchitis. So those two diagnoses need to be a red flag for you. And then ask about precipitation of symptoms by known triggers. So, for instance, every time I go to grandma's house, she starts coughing or wheezing, and they may not do both. So maybe she just coughs. Well, then you start asking about grandma's house. Maybe grandpa smokes in the house, or maybe there are cats in the house, or grandma lives out in the country and there are pecan trees nearby. Or perhaps it happens only at school and the school's cleaning with a strong bleach, or the teacher's burning a scented candle in the room. So those are some things that you want to ask about. Clinical manifestations of asthma. So there are, as you can see, numerous clinical manifestations, and a child may have one, two, or any combination of these manifestations. So the child may wheeze, and that's kind of what we typically think about with asthma. But the child may just have a cough. This might be the only sign, and then their coughing may be just at night. So do know that they don't always wheeze. They may have dyspnea. They may have sonorous crackles or rhonchi. So you may hear actually some crackles on auscultation, and this is why it's sometimes diagnosed as pneumonia. They may have prolonged expiration. So instead of the normal inhalation and exhalation ratio, the expiration may take 4 or 5 counts. So instead of 1, 2 in and 1 out, they may have 3 out or 4 counts out. They may have respiratory distress, and if you see a child with respiratory distress, this is not just a manifestation, this is an exacerbation. They may have sweating. They may present with decreased breath sounds, and just make sure you don't miss this. So when you're auscultating a child with asthma, you want to listen very carefully and make sure you're hearing good air movement. Decreased breath sounds may be a harbinger of respiratory failure. You've got to make sure that you hear this. So absence of wheezing does not rule out asthma, and especially in an exacerbation. Sometimes they may be exacerbating and they're not able to move air enough to even wheeze. And we'll talk about that later on when we're talking about treatment. But just remember that when you give a first treatment for a child having an asthma exacerbation, their wheezing may actually get worse initially and then get better, because what you're doing is you're opening up those airways a little more with a breathing treatment so that there's actually room to wheeze. So their airway may have been so constricted to begin with that they couldn't move enough air to make any noise. They may have difficulty speaking. This is also a harbinger of respiratory failure. Don't miss this. They may be irritable, anxious, or restless, difficult to comfort. These are all warning signs that your patient's about to go into respiratory failure. They may have chest tightness, decreased exercise tolerance, and the symptoms may worsen at night or with exercise. All right, so let's talk for a minute about some signs of respiratory distress. So these are the kids that are in trouble and you need to intervene immediately. Little kids, especially very young children, may have grunting or noisy breathing. Their respiratory rate will increase significantly. You may see retractions, and those retractions may be they may be anywhere. They may be in their belly, subcostal, intercostal, or clavicular. They may have nasal flaring, head bobbing, tripoding, so that they're sitting upright and kind of pushing down on both hands, and what they're trying to do is keep their airway open. They may have blue or pale around the lips and nail beds. They may have mood changes, be irritable, difficult to comfort, anxious. And just as an aside, if they are that way and they're sitting with their parent or caregiver, don't make the move. That's going to make them even more anxious. So you want to keep them as calm as possible. They may have clammy skin, using accessory muscles. They may have trouble speaking. If they have dark red lips that seem to be getting worse and progressing into cyanosis, this is a sign of significant worsening. You want to treat this immediately, and again, decrease breath sounds, so make sure you don't miss that. So when you are treating a child who presents to your office with what you think may be asthma, you want to think through other possibilities as well. So in your differential diagnosis, you want to include things like a pulmonary infection like bronchiolitis, pneumonia, or croup, mechanical obstructions of the lower airways like a foreign body, congenital malformations, vocal cord dysfunction, cystic fibrosis, gastroesophageal reflux with aspiration like we talked about earlier, pulmonary edema from cardiac or renal disease, and bronchopulmonary dysplasia. And we'll actually talk about BPD in a later lecture, in your respiratory lecture. But just know that that is also in your differential for asthma, and they present very similarly. And it's not terribly important that you are able to tease out which is which in a child that's premature, because the treatment is very similar, especially in an older child. And the younger ones, there's some other things we'll do, and you will want to tease that out, but we'll talk about that later on. So diagnostic studies, there's no test for asthma. So a parent will come in and present to you, and the patient will present to you, and the parent oftentimes will say, can't you just do some kind of blood test or an x-ray? And just education is the key here. And remember just to tell the parent, unfortunately, there's not a single test to test for the diagnosis of asthma. Asthma is really a diagnosis of exclusion. So what we do is we rule out all the other possibilities, and then we know that if we've ruled everything out and it's reversible, then in all likelihood it is asthma. So some of the tests we will do on a patient that presents with asthma, or with asthma-like symptoms, is we might do a CBC if we're concerned that there's a secondary infection like pneumonia. We may do a chest x-ray. We typically will do this with the initial presentation of persistent wheezing, or if we suspect a secondary infection. We also do a chest x-ray on any child with persistent wheezing that's under a year of age. This is not diagnostic, but you will often see hyperinflation of the lungs and flattening of the diaphragm, and possibly patchy infiltrates or atelectasis. This will also help you rule out things like pneumonia, or if you have one little area of atelectasis, you may be concerned with the foreign body. A foreign body that is made of metal will show up on chest x-ray, but remember, plastic foreign bodies will not, or anything other than metal, anything that's not radiopaque. A sinus CT we may do if we suspect sinusitis, if we suspect there are persistent, or if there are persistent allergic symptoms, we'll do an allergy workup. Sweat chloride if cystic fibrosis is suspected. I really would do this on just about anybody, especially if they're Caucasian. Most Caucasians, if there are GI symptoms such as weight loss or diarrhea, it's just always best to rule out cystic fibrosis. So especially on Caucasians, 1 in 20 Caucasians has a mutation has the gene for cystic fibrosis. So and it takes both parents having the gene for CF. So anyway, just kind of keep that in the back of your mind, that it's often a good idea to do a test for cystic fibrosis, and that would be your sweat chloride test. It's non-invasive. It's an easy test to do. They just wrap a band around the patient's arm and collect the sweat to see how much salt is in it. So it's really not hard to do. We may do O2 sat, and we almost always do that by pulse oximetry, especially during an exacerbation. Pulmonary function tests, so formal spirometry is the gold standard in children older than 5 years of age for diagnosing asthma. So what you're going to see on that is airway obstruction. You're going to see a decrease in the forced expiratory volume in the first second. So asthma is a disease of air trapping. So they can get the air in, they just can't get it back out. So you'll see some changes there. And then the other thing you'll see in pulmonary functions is reversibility. So if you detect airway obstruction and then you give an albuterol treatment, you'll see that airway obstruction resolve. We start in-office pulmonary functions or spirometry in children aged 4 to 5 years old. This is used to assess the severity of airway obstruction and to monitor the effectiveness of beta agonist treatments before and after the measurement. So formal PFTs are done in a hospital, but a lot of offices now have spirometry in the office, and it is important to go ahead and start that around 4 to 5 years of age to get the child used to it. They become more accurate at after about 5. And then, of course, in talking about PFTs, you want to consider using formal pulmonary studies for children with pretty severe asthma. Barium swallows, we use this to rule out a vascular ring or other forms of obstruction that's could be pressing on the airway. So while the barium swallow is not going to show the trachea, it does show the esophagus. And of course, the trachea and the esophagus run parallel. So if there is, say, for instance, a vascular ring pressing on the esophagus, chances are it's pressing on the airway as well. So defining asthma severity, these are the guidelines from the National Asthma Education and Prevention Program Expert Panel Report 3. So this is still the most recent guidelines, although we're working on the EPR4 now. There is a link in your notes to the guidelines, and those are the guidelines that we most often use in pediatric pulmonology in my practice. So the goals of asthma therapy is set forth by these guidelines. So everything I talked to you about with regard to treatment and diagnosis for the next few slides will be based on the EPR3 that I just showed you. So goals of asthma therapy, again, these are set forth by the 2007 guidelines. So as you can see, they're pretty old, but they are still relevant, and we are in the process of updating those. Symptom control, normal activity levels, and this includes being able to exercise and going to school. So we want the children that have asthma to truly be normalized in the way that they, in their activity levels. We want them to be able to participate in their sports competitively if that's what they want, or to go to school, or to do whatever it is that they want to do. We want them to have normal pulmonary function, so that's as indicated by spirometry. We want to prevent exacerbations, avoid the side effects as much as possible while treating the asthma to the extent that they can have normal activity levels. And then, of course, we want to prevent mortality. So the EPR3 recommends control in both of these areas, in impairment and in risk. And this is critical because pediatric patients with persistent asthma symptoms, they have an increased risk of exacerbations, hospitalizations, ER visits, and oral corticosteroid use with exacerbations, leading to progressive loss of lung function. And eventually that lung function or loss of lung function becomes permanent. So we want to make sure we address impairment and risk when we treat pediatric patients. Now this is kind of small for you to be able to see, but it does give the classifications of asthma severity and how to initiate the therapy. And this is in the EPR3 guidelines. So their main areas of assessment, you first assess degree of impairment. So you want to assess symptom frequency, number of nighttime awakenings, short-acting beta agonist use for symptom control, not for exercise-induced asthma prevention, but just for symptom control. We'll talk about that in a little while. Interference with normal activity, and then you also want to assess lung function. So you want to look at the FEV1, the forced expiratory volume in 1 second, and then the FEV1 to FVC ratio. So that's the forced expiratory volume in the first second as compared to the forced vital capacity, so the full amount that they're able to exhale. How much of that air were they able to get out in that first second? And that's based on norms for age and gender and for race, and those comparison values will come up in your spirometry when you perform it. You also want to assess risk, so the frequency of exacerbations that require oral systemic corticosteroids. In treating patients with asthma, we want to treat them to the fullest extent or to the extent necessary to keep them off of oral corticosteroids. This is just the severity classification for 0 to 4 years of age. And you can see, looking at the symptoms, it helps you classify intermittent and then persistent asthma. And there are 3 divisions of persistent: mild, moderate, and severe. And it's based on the symptoms. So how frequently do they have symptoms? How frequently do they awaken at nighttime? How often do they have to use the SIBA or short-acting beta agonist? And how much does it interfere with normal activity. And then they have recommendations for initiating therapy. And you can see at the bottom it's steps 1, 2, and 3. And those steps will be in a later slide to tell you what to do to intervene for asthma. All right, and this is the classification of asthma severity for children ages 5 to 11 years, and it's the same sort of guidelines, but starting at age 5, you can see it also gives you the lung function. So it tells you what their lung function should be, and and based on their numbers, what their classification is. And then this is the same chart for children over the age of 12 and adults. All right, so the stepwise approach to asthma management. The first chart, again, this is from the EPR3, shows you the stepwise approach to managing the asthma, so managing a patient's asthma. So remember back on the previous slide, the classification slide, it told you based on their symptoms which step to use for asthma treatment. So in the first step, all that the recommendation is for intermittent asthma is just short-acting beta agonists as needed. So these are the kids that rarely have symptoms, less than twice a week and less than 2 nighttime symptoms per month. And for those children, all we're going to do is give them an albuterol inhaler or nebulizer to use as needed. Now you can see as the severity of symptoms increases, so does the treatment. So we step up from, based on the level of severity, we step up the treatment. And once you get up to about step 3, the recommendation is that those children be referred to an asthma specialist. So an asthma specialist is a person who has specialty training in asthma care, and that's usually a pediatric pulmonologist or a pediatric allergist. In some parts of the country and in some areas where there are not pediatric pulmonologists or pediatric allergists available, then it can also be a person who has extensive experience in treating asthmatics, and usually those people are also certified asthma educators. So again, here's the stepwise approach to management, and all this is that previous chart laid out in a stepwise approach. So you can see step 1 is just short-acting beta agonist as needed. At step 2, you're going to add a low-dose inhaled corticosteroid, and that's for all ages. And those are things like Flovent or Pulmicort, Respules. Those are your single agent inhalers. You can use cromolyn or montelukast. Montelukast is Singulair by itself. We hardly ever use theophylline. I see that that's listed there. And then you want to consider immunotherapy for allergens or for the allergic component at step 2. At step 3, you're going to increase the dose of that inhaled corticosteroid. So maybe you did Pulmicort 0.25 or Flovent 44 at step 2. At step 3, you're going to go up to Pulmicort 0.5, or perhaps you'll give Flovent 110 micrograms. And that would be 2 breaths via spacer twice a day. And we'll talk about the dosing a little more later on. Also at step 3, you may start considering using an inhaled corticosteroid plus long-acting beta agonist. So this would be like your Advair, Symbicort, or Dulera. Or you may use a low-dose combo product or a medium-dose inhaled corticosteroid. Now, the combination products are, and medium-dose steroids are for greater than 12. And then alternatively, you could use a low-dose ICS or an LTRA with theophylline. Again, we just don't use theophylline much anymore. We have better medicines available that don't have the side effects. All right, step 4 is a medium dose inhaled corticosteroid plus LABA. So you're going to bump up your Advair dose, or your Dulera, or your Symbicort. And then step 5, you're going to use a high dose ICS plus LABA, and or Montelukast Singulair. Now, at step 5, you're going to start thinking about using a biologic such as Xolair, and we'll talk about that later on as well. And then step 6, you're going to bump things up even more. So at step 6, you're going to use a high dose ICS and LABA combined, plus you're going to probably have to add an oral corticosteroid. Hopefully these children are under the care of an asthma specialist by this point. All right, remember at every step you want to include patient education, environmental control, and management of comorbidities. So anytime you see patients with asthma, anytime you have to change their medicine, you want to talk about these things again. You want to include education. You want to talk about what they can do to control their environment better, and then how to manage comorbidities such as allergies or reflux. You're going to increase the short-acting beta agonist use. An increase in short-acting beta agonist use may indicate poor control and a need to step up the treatment. So if they've been well controlled on, say, step 2 therapy, but now they're having to use their short-acting beta agonist more than twice a week during the day or more than twice a month at night, then that tells you your control isn't good. So it's time to reevaluate and bump those steps up. So go up a step, and then after you change a medication, you always want to follow up in at least 1 month. So when you first see an asthmatic in your office and you feel certain that they have asthma, the first thing you're going to do is initiate therapy. You are always going to demonstrate device use, and if possible, have them return the demonstration. And you're going to go over an asthma action plan, and we'll talk about that later. And then you're going to reassess them. So when they come back, you're going to have them come back in 4 weeks. They're going to perform an ACT test, which is just a little questionnaire about their asthma control, or some other self-reported test. And you're going to do a physical assessment and spirometry at their follow-up. If they are not severe when they present to you the first time, that follow-up can take place in a month. If you have some concerns, you can follow up sooner than that, 2 weeks, 1 week, even 24 hours if you are really concerned. So the Asthma Action Plan is standard of care for all children with asthmatics. The goal for the Asthma Control Initiative work group in the state of Georgia is to improve compliance with asthma action plans from providers to the school system. So what's happening is maybe about 30% of kids are leaving their provider's office with an asthma action plan, but we'd really like to get that up to 100%. That is standard of care, that they have an asthma action plan. And what the asthma action plan does is it lays out their asthma plan in an easy to follow stepwise approach for parents, for caregivers, for babysitters, for the school. So if they are in the green zone, and you can see at the top there's just a place for demographics. If they're in the green zone, then that means they're doing well. Green means go. So they're just going to do their maintenance medicines every single day. And if you're doing a peak flow on them or having them do peak flow, then they'll do that every day. I did not do peak flows. They are not universally recommended because A, they're easy to manipulate, and B, when you already have a child on a significant number of meds, you don't want to add something else, especially something that is so easily manipulable. The yellow zone means that the child is starting to show some exacerbations. They may be having an increase in symptoms, and you'll write down in the yellow zone what they're to do. So they're to continue their maintenance meds, and in addition to that, perhaps you'll have them do albuterol, 2 puffs via spacer every 4 hours as needed. So you're going to write specific instructions so that they know how to treat this. And it has the symptoms listed there on the left. So it tells them, all right, when you do this, when you have these symptoms, these are the steps that you take. Then when they get into the red zone, this shows that they have very poor control. At this point, they need to call 911 or get to the emergency room, but it also tells them the steps that they can take while they're on their way to the emergency room, such as using albuterol inhaler, or maybe taking a dose of oral corticosteroids if they have those at home. All right, so let's talk just a minute about the medications that we use in asthmatics. So when you're treating an asthmatic, they have two categories of medications. They have their rescue inhalers, or their rescue medicines, and these are the medicines that they use just when they're having an asthma exacerbation. And then they have their preventive medicines, and those are the ones that they use every single day, whether they're having an asthma exacerbation or not. So these are the ones that they use every day to help prevent them from having an asthma exacerbation. Parents tend to get these confused, so it's important that you review the uses of the medication with them every time they come in, because they'll come in to you and they'll say, well, he had an asthma attack the other day, and that Flovent that you gave him just doesn't work. He used the Flovent and he didn't get any better. Well, that's because the Flovent is an inhaled corticosteroid, and it takes it days to weeks to work. It's not something that's going to work within 30 minutes like a short-acting beta agonist. So that education component will really help parents understand their medications better, and also the asthma action plan will help them understand. So let's talk for a minute about the rescue medicine. So we'll talk about this first, and then we'll talk about their maintenance medicines. So rescue medicines include albuterol, ipratropium, and racemic epi, and then in severe cases, theophylline or mag sulfate. So when a child is having a bronchospasm or an asthma attack, we use aggressive bronchodilation to reverse the bronchospasm. So we're going to do this with albuterol. So there are several forms of albuterol. You can give it via nebulizer. It is also available in a metered dose inhaler and in a dry powdered inhaler. So you have to know the techniques for each of those. So if you're giving albuterol via nebulizer, the dose is 2.5 to 5 milligrams every 20 minutes for the first hour if they're in your office having an attack. If they're going home with albuterol, it's every 4 hours. So 2.5 to 5 milligrams every 4 hours. If they are having a severe attack and they are in your office or in the hospital, then we do continuous nebulization if we need to. But just remember, for home use, they'll use 2.5 to 5 milligrams every 4 hours. It's important that you tell the parents that if they find that the child needs albuterol more than every 4 hours, they need to get them seen immediately. So don't wait until morning. If you're given if the child needs an albuterol nebulizer every 2 hours or every 3 hours or every 30 minutes, get them to the emergency room immediately. If they have to use the albuterol every 4 hours for more than 48 hours, so for more than 2 days, they also need to be seen by a healthcare provider, because they're just not regaining control like they need to. Now, the other way you can use albuterol is via metered dose inhaler. This is used with a spacer every single time. So if they're at home, then you give them 2 puffs every 4 hours as needed. So you can use a spacer with a mouthpiece or a spacer with a mask. And I have some instructions on how to use each of those later on in the presentation. If they are in the office setting or in the hospital, they can use between 4 and 8 puffs of the inhaler. Occasionally, for severe exacerbation, we'll use 10 to 15 puffs, but that's very rare. But it must be used with the spacing device. So that's kind of your rule for the day to remember, is all meter dose inhalers have to be used with a spacing device. And we'll look at that later on. Now, moving on to ipratropium. This may augment the bronchodilatory effects of a short-acting beta agonists, we very rarely use ipratropium by itself. Ipratropium is a short-acting anticholinergic. It's been used to treat asthma for years, but it is not as effective as a short-acting beta agonist like albuterol in achieving acute bronchodilation. Some research has shown that in combination with the SABA, it's more effective than in treating acute asthma exacerbation with the SABA alone. So it does help augment the effects of albuterol. Racemic epi, we do this in the ER only. We give 2 cc's as a nebulized aerosol. We use this more for stridor or croup, but occasionally we will use it for wheezing. And then theophylline or mag sulfate. These are only in extreme cases, and these kids are in the pediatric intensive care unit. The anti-inflammatory medications that we use for an asthma exacerbation include methylprednisolone IV. The dose of that is 1 milligram per kilogram every 6 hours to a max of 60 milligrams per dose. We also use prednisone, PO, and that's 2 mg per kg per day. I usually divide that to BID, and you would use that in a tapering dose if you have to use it for more than 2 or 3 days. So you do 2 mg per kg per day for 2 days, and 1 mg per kg per day for 3 days, and then stop. And all of these medicines may require a tapering dose. Now, moving on to the preventative medicine. So these are medicines that asthmatics will use every single day if they are persistent asthmatics, so mild, moderate, or severe asthmatics. So intermittent asthmatics do not use these preventative medications, only persistent asthmatics. So just remember, the goal of the therapy is to use the minimum daily dose necessary to control the symptoms and normalize pulmonary function. So inhaled corticosteroids, these would be things like Pulmicort or Flovent. Some people will use Q-Bar. Mast cell stabilizers such as cromolyn, we don't use those much anymore. They have very few side effects, but they didn't do a particularly great job at preventing asthma exacerbations. Long-acting beta agonists such as Ceravent, which is formoterol, salmeterol, those we do not use by themselves. We only use those in combination therapies such as in Advair or Symbicort. Or Dulera. And that's the combination med that's mentioned next, the ICS plus LABA, and then leukotriene inhibitors. And those are medications like Singulair and Accolade. Inhalation devices. So there are different ways that we can give these inhaled medicines like the albuterol or the inhaled corticosteroids. So we can use a meter dose inhaler with an air chamber, and that's what you see there in the picture. So anytime you use a puffer, as the kids will often call it, or a meter dose inhaler, you must use an air chamber. I don't care how old the patient is. I still use an air chamber with my inhalers. So it doesn't matter the age. What the air chamber does is it gives it increases the turbulence of the flow of the medicine. So what it does is it helps propel the medicine back into the airway where it needs to be to work. So if you don't use an inhaler, an air chamber, even with perfect technique, a lot of the medicine, or most of it, will sit on the teeth and tongue. So that increases the chances of thrush if you're using an inhaled steroid, and it also decreases the chances that the medication will work. Another inhalation device is a dry powdered inhaler. There are different types of dry powdered inhalers. These are breath activated devices, so they don't work particularly well on young children. Usually 9 or 10 is about the youngest you can use a DPI because the kid has to have perfect technique to make these work. With a meter dose inhaler with an air chamber, if they don't have good technique, you can use an air chamber with a mask. And then lastly, we have nebulizers, and these are what we give to very young children. Medicaid will pay for nebulized medications up till the age of 9. After the age of 9, they won't pay for it even if the child has something like cerebral palsy that prevents them from being able to use good technique. So that's when you start having to use a meter dose inhaler with a mask. All right, so this poster is a really handy poster to have. I'm sorry we're not doing this in person. When we do, I usually have copies of this to hand out. It's respiratory inhalers at a glance. I would recommend that you look it up online, and I give you a link in the next slide, and that you have a copy of this with you at all times when you're seeing patients. What this does is it allows the patient, they can almost always point to what their inhaler is. So you may say, well, what inhaler are you using? And they'll say, well, it's the orange one. Well, there are a lot of orange ones. But if you show them this poster, more often than not, they're able to point to the inhalers that they're using at home. Or if they say, well, I took I had an asthma attack the other day and I took my purple inhaler. Well, you can show them this poster and you can see that they're going to point out that their purple inhaler is Advair, which is not what they need to be using in an asthma attack. That's a maintenance medicine. So this is a very helpful poster to have around. Most of the drug reps can get them for you, or you can download them from the Allergy and Asthma Association. They come in an 8.5 by 11 and in a poster size, so I try to always keep those available when I'm seeing patients. And there's the link for the inhalers at a glance. They update this every 2 to 3 years, so just make sure you've got the most recent copy of it. All right, so let's say that you've got an asthmatic that comes into your office and they're having an acute exacerbation. So this the patient has come in, they are wheezing, maybe they're coughing, maybe they're anxious, they're having a hard time breathing. So what are you going to do? Well, the main goal is to control the airway inflammation and the bronchospasm. So when they first come into your office, you're going to check a SAT on them if you're able. Go ahead and apply oxygen, even if their SATs are on the low end of normal. This just helps them breathe. It helps them improve their oxygenation. The next thing you're going to do is you're going to consider hydration. So if you've got them in the hospital, you're going to probably go ahead and have them start an IV. They do tend to dehydrate pretty quickly due to insensible water loss from mouth breathing. Dehydration can cause the secretions to be very thick and can cause plugging and atelectasis, and it can cause a VQ mismatch and worsen hypoxia. So you want to make sure the child's hydrated. You want to keep the child calm. So like I said before, if they are happy sitting in grandma's lap or in mom's lap, let them stay there if you are able. Now, if they are so ill that you have to put them in the bed or on a surface that you can work on, then by all means do so. But if you can keep them calm sitting with their parent, then do that. And then you want to administer their medications. So rescue medicines that we mentioned before, like albuterol. So I think we've covered all of that. Yep, I think we've gone over all of that, and that's for an exacerbation and for status asthmaticus. Of course, if they're in your office and they're having an exacerbation that is beginning to look like status asthmaticus, you want to call 911 and get them to the emergency room. But these are the things you're going to do to keep them stable while they're still in your office and while you're waiting for emergency help. All right, so let's talk for a minute about treatment failure. So let's say you've had an asthmatic that has come into your office. You've been trying to treat their asthma. You're using the recommended approach, the stepwise approach, and they're just not getting any better. The parents are bringing them in and they're saying, he keeps wheezing, he's using his short-acting beta agonist, he's using his albuterol 3 or 4 or 5 times a week, several times a day. He's coughing all night, every night. So let's talk about why they may be having treatment failure. So the number one cause for treatment failure, or the top 2 causes, are either non-compliance or poor adherence with controller medicines, or oftentimes it's also due to not using the medication, the inhalers properly. So we'll talk about that in just a minute. So let's just remember, poor adherence has several causes. It's not just that the parent or the patient doesn't want to do their medicines. There are often many reasons for poor adherence. Might be that the treatment is so complex that they can't understand it. It may be related to cost of medications. Um, they may be concerned about the risk of the medications, the side effects of the medications. It may be because of low parental health literacy. So maybe the parents just don't understand what you're telling them. It may be due to lack of parental supervision, family socioeconomic strain, poor patient or parent perception of the disease severity, or maybe there's secondary gain from poor asthma control. So it can be any one or a combination of these. Maybe the patient is going to different homes. So I had one patient who I could not seem to get her asthma under control. And when I sat her down and talked to her about what was going on, she was spending one night at mom's house, one night at grandma's house, and one night at her aunt's house because her mom was working. So her asthma medicines weren't always going with her from place to place. So grandma might pick her up from school one day, mom one day, and her aunt picked her up one day. So if you can really sit down and talk to them about what's going on, make sure that you're being very non-judgmental and that they understand that you truly want to understand why they're not using their medicines. Oftentimes you can help them. What I would oftentimes say to a parent is, first of all, you want to say to them, tell me about your medicines and how you're using them. And they'll say, well, however you told me. Well, ask them, just say, well, let's make sure that I educated you, that I gave you the information that you needed when I last saw you. So put it all back on you. Don't say, well, let's make sure you understood me. Let's say something like, tell me what you understood me to say or what it sounded like I said to you. I want to make sure that I said everything right. And then let them talk to you about what they've been doing. And that's when those respiratory posters may come in handy. And you might find out that they didn't understand you or that they can't afford their medicines, but really try to understand where they're coming from so that you can help them. They may also just not be responding to the therapies that are available. And in that case, you need to reevaluate what you're doing or perhaps refer them to a specialist. Again, it may be due to improper technique with their inhaler devices. I always have asthmatics bring their inhalers with them every single time they come in, and I review their technique. You'd be amazed how just one little change in their technique can make a world of difference in their responsiveness. They may have poor control of comorbid conditions, so perhaps they're using their asthma medicines like you've told them, but they're refluxing and they're not on reflux medicine. There may be psychosocial stressors, or they may have been misdiagnosed. So it's important to entertain all of these possibilities as reasons for treatment failure, but to do so in a very non-judgmental way. Sometimes for teenagers even, I'll ask them, I've prescribed this Flovent 2 puffs twice a day, and I've called the pharmacy and they've talked about when you got it refilled, and I found out that you haven't had it filled for 2 months. Now, it doesn't seem to me like you're using this medicine based on that. Tell me what's going on with that. Tell me what you're thinking. What's going on and why is it not being used? And they may say, well, I don't like it. It makes my mouth taste bad. I don't have time in the morning. Teenagers will have all kinds of excuses. So you kind of have to meet them where they are. So sometimes what I'll do, even though it's not ideal, is I'll change the medicines around on their schedule. Or if they forget in the morning, I'll tell them to take a rubber band and put it around their toothbrush and their inhaler. And that way, because they're certainly going to brush their teeth twice a day. And then I'll tell them, use your inhaler first, brush your teeth second. Always brush your teeth after your inhaler because it'll keep you from getting thrush. But if you have right there with their toothbrush. That gives them a visual reminder to do it. So just really talk to them. This dialogue is very important for you to understand why why the medicines aren't working and what you can do to help. All right, so let's talk a minute about causes of asthma deaths. So asthma deaths are usually, but not always, caused by a combination of insufficient therapy. There may be a delay in the use of appropriate rescue medicines or a delay in seeking medical attention during an exacerbation. So maybe they're using their albuterol every 30 minutes at night, but the parents don't want to have to call the provider. So maybe they delay calling, or non-compliance with the treatment plan. So proper education can help prevent many of these issues. That's why education is so important, so that they understand how to use their medicines and when to use their medicines, when to seek medical attention. And you also want to make sure you've got them on the right medication. So make sure that you're not afraid to use these inhaled corticosteroids or these combination products when they need it. So when do we refer? We refer any patient who has had a life-threatening exacerbation. So any patient who's had a hospital admission or a PICU admission, those kids need to be referred. Don't try to manage that on your own. Get an expert to help you out. If they're not meeting the goals of therapy after 3 to 6 months, or sooner if they're not responsive at all. If they have any signs and symptoms that are not typical of asthma. If they have any other conditions that complicate asthma or its diagnosis. So if they have reflux that's not responding, you want to refer. Any patient that requires additional education or guidance with compliance to therapy, side effects of treatment, or allergen avoidance. Or if a patient is being considered for immunotherapy, you want to send them to a pediatric allergist. Any patient that requires step 4 therapy, or in children that are younger than 4 years old, step 2 or 3. And I think I said step 3 therapy earlier, but it's actually step 4 therapy. So step 4 therapy or 2 or 3 if they're under 4 years old. Any patient that has had to have more than 2 bursts of oral steroids in a year, just remember that it is safer to use and you have less systemic steroid absorption if you use an inhaled corticosteroid year-round, 365 days a year, than it is to do 1 burst of oral steroids in a year. So if you're having to give oral steroids more than once or twice a year, you really need to send them and let somebody else take a look at them. If they have an exacerbation that requires hospitalization, if they have a history that suggests occupational or environmental inhalant or ingested substance has caused the asthma or exacerbating symptoms. So if you've got somebody that maybe has been exposed to asbestos, they need to go see a specialist. If there's any psychiatric, psychosocial, or family problem that interferes with therapy, so they may need to go to counseling, they may need to have psychiatric help. So referrals, who are you going to refer to? To an allergist, a pediatric pulmonologist, or a healthcare provider with skill in asthma management from extra training or experience. And this is as set forth by the EPR3 guidelines that we talked about earlier. Referrals for conditions complicating asthma should be referred to ENT for sinusitis, a pediatric gastroenterologist for reflux, or psychologist or psychiatrist for issues complicating the treatment, like psychiatric disorders. All right, so let's talk for just a minute about biologics. Biologics are probably not going to be done in your office, or they're certainly not going to be prescribed in your office. These are usually prescribed by an asthma specialist. So palivizumab, which is Synagis. This is a monoclonal antibody that's directed against RSV. This will sometimes be done in the primary care provider's office. Synagis and palivizumab's impact on the development of asthma in children at high risk for asthma has not been studied long-term, but there's been a small study that indicates a possible preventative effect in children with no risk. We don't use it in children with no risk right now. Right now, it's currently used only in babies that were born premature, babies with chronic lung disease like BPD, and babies who have congenital heart disease. And these children are all under the age of 2. Omalizumab, which is Xolair, is an anti-IgE monoclonal antibody. So we use this for severe asthmatics who have severe allergic asthma with well-documented effects on the risk of exacerbation. So this causes a significant reduction in free IgE levels. So part of the determining factor for using this is testing the patient for IgEs, and they have actually an algorithm you can use to determine whether or not they are eligible for Xolair. One study shown a residual effect on asthma after discontinuation of therapy, which suggests a modifying effect on the natural history of asthma. More research is needed to determine if this effect could be preventative in patients at high risk for asthma. Currently, we're using it only on severe asthmatics. It also has been shown to reduce airway remodeling by changing the thickness of the bronchial basement membrane. Xolair is given to teenagers. It is thick as snot, and it hurts like the devil going in, but it makes such a significant difference in their asthma that they willingly come in. So teenagers who are traditionally very non-compliant will show every single time for their Xolair injection. It's given usually every 2 to 4 weeks because it does make a significant difference in their asthma. Nucala is a humanized monoclonal antibody directed against IL-5, which causes an increase in eosinophils. By decreasing the eosinophil count in asthmatic patients with Nucala, asthma exacerbations are decreased. So the studies are promising with adults and adolescents. We still need some more studies in pediatrics. All right, allergen-specific immunotherapy. So this is subcutaneous immunotherapy, what people call allergy shots, and now we're using sublingual immunotherapy. Subcutaneous immunotherapy or allergy shots have been around for more than 100 years. So those have been well studied, well documented. They show an improvement in allergies and in asthma. Sublingual immunotherapy using drops or tablets has been studied for about 15 years now. The research has shown that subcutaneous immunotherapy resulted in a decreased risk in developing bronchial hyperresponsiveness, asthma in children who also have allergic rhinitis. Sublingual immunotherapy is showing some promising results, but it's not as consistent as the allergy shots, so it's not being used quite as frequently. All right, so discharge planning in an asthmatic. If the patient is in the hospital or in your office, discharge planning begins the day that the child is diagnosed or admitted. Asthma therapy is a key component to good asthma control, asthma education rather. It increases compliance and it allows the patient to take an active role. So giving good asthma education empowers the patient and the parent in their disease control and in decreasing morbidity. So this is the most important component of discharge teaching or asthma teaching. You want to teach them to recognize and avoid triggers. You want to teach them about medications and techniques. Teach them signs and symptoms of exacerbation, and you always, always, always want to give that written asthma action plan that we talked about. Here are some resources for you. So there are 2007 guidelines from the National Asthma Education Prevention Program, EPR3. That's what we talked about earlier. The CDC also has some good information, and the Asthma and Allergy Foundation of America. Asthma prognosis. Although asthma incidence and death rate is increasing, it actually has an excellent prognosis. Asthma should not be a debilitating disease. Good education and therapy should allow patients who have asthma to lead a normal life without any limitations, other than the fact that they'll have their inhalers with them. Another resource for asthma management for your asthmatics, and I have former students that contact me all the time about asthma therapy. Anytime you have questions, you guys have my cell phone number, you have my email address, it's in the syllabus. Please feel free to contact me anytime. If I don't know the answer, I will know who to put you in touch with to help you get the answers that you need. So if you have questions or if you need any clarification, please feel free to email me and ask any questions that you have about this lecture.